Good morning, everyone, and welcome to Mastering Clinical Excellence, the synergy between risk management, quality, and medical staff services. My name is Christina Cabral, and I sit on the NAMS board as a director at large. I have a couple brief reminders that you've heard in all of your sessions, so just please remember, check your cell phones and your pagers to make sure they're silent. It's very important when you finish up today that you complete an evaluation and drop it off to one of our room monitors. And also, please remember that this session is being recorded. There's a microphone in the middle of the room. If you have any questions or comments, either during or after the presentation, please make sure that you use the microphone. All right. I will confess that I was given 3 pages of bio sketch information about these 3 individuals on the dais. So rather than tell you about all of their degrees and their careers and their contributions to quality healthcare, I thought I will just let them demonstrate their knowledge and expertise throughout the presentation today. So, ladies and gentlemen, it is my pleasure and honor to introduce what I've now called the Past Presidents Club. So, if we start with Susan Goodwin, who is the 2011 President of the National Association of Healthcare Quality. We go to Michelle Hoppus, who is the 2011 President of the American Society for Healthcare Risk Management, and then to our own Kate Conklin, who is the 2011 President of NAMS. So please join me in welcoming this amazing trio.
Thank you. Thank you, Christina. Thanks for all you've done on the board this year. She's been a great board member. Can y'all hear me in the back? I can never seem to get this up. Okay. Well, we are very excited about this presentation. The 3 of us talked about coming together and talking about how we work together and the information that we each kind of own and need to share. Probably must have been a year that we were president, or maybe even we were working on the NACU call to action paper. And so we kind of hatched out this idea, probably written on a little bit of a cocktail napkin, but we really got so excited about talking about how these 3 areas of healthcare really need to come together. And there's no better time now than if you heard the keynote yesterday. You've probably heard a lot of sessions that have talked about it is all about coming together now and caring for a patient. It takes a village. It takes a team. So we're very excited that we were finally able to kind of get our initial thoughts together and put this presentation together for us. So I hope you enjoy it. We are going to introduce some new terms to you. This is going to be truly some education that you'll be thinking about, hopefully, when you leave here. So ask us questions either during the session or find us afterwards. So I don't have my clicker, but here are the objectives. So we're going to look at our roles and responsibilities. We're really going to focus on patient safety. All of our roles now are really turning it into patient safety. We're going to talk about this collaborative model that integrates all 3 of these disciplines, especially in relation to medical staff and medical staff services, to demonstrate the benefits and barriers to the organization, because there are some. And then we're going to talk about the change in healthcare delivery model that you've been hearing in various ways, but how it really directly relates to the work that you do. Well, that's us. Okay, so why this session? Why now? So Susan put this together for us. These are just the books that have been, what did you say, they pop up as recommended reading?
Right.
Susan's Amazon. On some kind of list. She's on a watch list somewhere where they're like, that's all that woman reads about.
Past reading interests, they tag you.
So isn't that incredible? I know most of you have read some of these books. I know you've read one in the corner, hopefully. And I'm the same way. This is what I read. I'm not into the little romance novels anymore. I have no time. This stuff is compelling, especially as doctors are starting to write their stories. You heard the doctor yesterday. So it's out there. It's in front of us. That's us again, in case you didn't know who we were.
There we go.
So this really kind of, after you take that whole list of reading now, you kind of look at some of these things that have been published over the last 10 years. Certainly, to err is human was really the wake-up call for us. It really was. But we're 10 years later, and we have not improved. We've not improved enough to where we need to be. So as you can see, some of these very significant publications, we talked about the Checklist Manifesto yesterday. He talked about that. Now we're looking into IT. IT is all part of this. Every single facet of healthcare has got to come together. ACOs are forming. The role that we're going to talk about today, your role specifically, and where you fit in that collaboration. All right, so we're going to do something kind of fun. Makes us a little nervous. We're not real thespians, but we've decided to take you to a little scenario that we're going to do right now and see what your reaction is to it. So we're having a meeting at a hospital, and I'm walking in the door right now. Well, it's so great to see risk and quality here at this meeting, but where are the doctors? Once again, they don't want to come to these meetings. They just seem to hate to come to any meetings where we talk about quality and risk.
I know what you're saying, Kate. I'll tell you. We're pulling in long days. I feel like we're just working our butts off, trying to do all this analysis, get all these reports pulled together. And where are they? We need them to make decisions. We can't really move forward without them. For that matter, where's administration at this table? I don't know how we're going to meet all these measures. What is it? HCAPs, core measures. There'll be new measures tomorrow, I'm sure. We can't do it without them.
Well, even more concerning are the few physicians who are downright obstacles to us making any progress, like our friend, Dr. Retro. When I started 10 years ago, he was already here 15 years before that. Talk about set in your ways. With his high volume as a surgeon and his loyalty to this hospital, administration pays attention to whatever he says, and it's all about keeping him happy.
I know. He's grumbled for years about government control. He hates the core measures. He says all that evidence-based medicine, that's just nothing more than cookbook medicine.
Oh, you think that's a lot. Last time Joint Commission was here, do you know what he did? He made this rude remark about how he doesn't believe in their standards. Oh, I was so embarrassed.
He's a real challenge for the quality department. He ignores data about his higher than expected surgical infection rates, his frequent post-op readmissions, his delinquent records, his illegible handwriting, and if he just used our EHR system, but he refuses, and his lack of competence or compliance in the OR to universal protocol, it's concerning to hear the OR nurses talk about his attitude. But he just says that after all, he's never operated on the wrong patient or wrong site yet.
So you think he's a challenge for quality? Huh. You ought to be the risk manager in this place. Even his latest lawsuit hasn't really woken him up. Believe it or not, he told me. Complications, they're just an expected part of healthcare.
Wow. You know, and what's really weird is he was the chief of surgery in the past. He has a high level of credibility with the doctors. They all revere him. They consider him a mentor. You know, the current medical staff leaders now find him impossible to deal with, and they prefer to live and let live, but administration is happy when the revenue brings in the money, and they'd rather not rock the boat. But Dr. Retro is very vocal with his opinions. Hospital staff are demoralized with their encounters with him, and they fear his presence on the unit. So do you all have that doctor in some fashion? I apologize for the surgeons out there. We hate to profile them. So obviously, I think this would be familiar in your facility. So what problems can you identify with that little scenario right there? Just what were some of the problems that just kind of jumped at it? Sorry, say that a little louder. Right, right. And isn't that typical? How many meetings do you go to? I mean, aside from medical staff meetings, we spend our lives in meetings, and the person that we need at the table, the stakeholders that need to be involved in things are doctors, for sure. So what might be some of the causes of that? Why are doctors not there? Because they don't see that they don't see that role yet. They don't see that. They're still in the grumbling, we must be part of the problem, because they're frustrated. So what is the impact on others that work in the facility when there's that type of culture? When there's that lack of communication? Right. And how do you keep people highly engaged? We've got highly trained people in these organizations, and how do you keep them engaged when you have that type of culture? So we're going to talk about the tsunami and how we can avoid it. So y'all know what a tsunami is? So it's an earthquake that happens somewhere, happening right now, but you don't see it. But what you do see, the waves coming. So that's why we've coined it the tsunami. It's going to take a culture change. It's going to take a lot of change that we're all going to be involved in. So Michelle's going to lead us through some of strategies related to risk management.
Good morning, everybody. Can you hear me okay? Is this up high enough? Great to see you. So the tsunami. Well, I got to tell you, not quite loud enough? Okay, let's see if I can get this a little bit higher. How's that now? So-so? Try this one. That better? Oh, it'll be a challenge for me to stay this close to this, but I will definitely try. I might even have to put my glasses on now. All right, so anyway, we're talking a little bit about a tsunami. I think we had a tsunami in healthcare, and I'll tell you when I think that occurred. It was in 1999. Does anybody know what happened in 1999? The Institute of Medicine came out with a report called To Err is Human. I have to be honest with you, I don't think healthcare has been the same since. I remember as a risk manager at that time sitting in my office reading that book and just going, yes, somebody gets it besides me. And I really felt that that would change patient safety and where healthcare was heading. And I do think that that truly was the catalyst for where we're at today. So what you see up here is just a few of the key elements in regards to a patient safety culture, and I want to talk to you just a little bit about a few of these. First is top-level commitment. What does that mean? Administrative level. Weren't we just talking about that in this scenario? That was a really important meeting, and who were we missing? The top level. So the first part of maintaining, sustaining, or creating a patient safety culture is top-level commitment. But is that where culture is the strongest? No. Culture is actually the strongest at the front level, or what you'll hear me talk about, the sharp end. But if you don't have top-level commitment, if you don't have a vision from the top that's clear, pretty difficult for the sharp end or for the front line to really be able to establish that patient safety culture. So it does involve everyone at every single level. The three of us have sometimes talked about patient safety, and we've even used these terms. You know, who owns patient safety? Is it risk? Is it quality? Is it medical staff? We all do. Nobody owns patient safety. We're all responsible for it. I heard your president in the opening make a comment that I really liked, and it so resonates with me. I see medical staff services as the gateway to patient safety. I wrote that down, and if you guys don't communicate within your own organizations that you are the gateway, I truly believe you are. If we can get it right at the front end, before we bring up upon our organizations, healthcare providers, if we really do a good job with what you do, a lot of what Susan does to prevent defects, a lot of what I do to correct them after they happen, we won't have to spend our time there. So organization evolution, clearly. I mean, you may have some pockets in your organizations where the culture is very strong and others where it's not, but it takes time. And then commitment. I think really what you see as far as what's happening is certainly going to be the strongest demonstration of commitment. And what I mean by that is, let's say that the budget's cut, and it's cut all around patient safety areas, that suddenly we can't continue to advance in regards to new equipment or repairs that we need. That speaks volumes to frontline staff around commitment. And then the last one, culture transcends leadership if successful. What that really means is it shouldn't be about one person. So I've heard medical staff and other individuals say that, you know, clearly, if we're having a great year around quality and patient safety, they'll say it's because we've got such a great chief of staff, but just wait till next year, it's not going to be so good. That's not truly a patient safety culture. It can't be about one person. So in the Institute of Medicine report, they said there were about 98,000 patient deaths per year. I don't know how many of you read that or remember it. What did we hear from our opening speaker, Dr. Macri? CDC's updated that. So we used to be the 8th leading cause of death in the United States was medical error. We've moved up. I don't think any of us are proud of that. We're now 3rd. The 3rd cause of death is medical error. 210,000 deaths now they anticipate versus the 98,000. Well, there's been lots of discussion and, to be honest with you, argument about what's the right number. Hopefully, all of us in this room understand it's not about what's the right number. Any number's too high. So let's take a look at some of the characteristics. You'll see many concepts up here. A blame-free environment. The Joint Commission, when they came out with what they called their non-punitive reporting standards many, many years ago, to be honest with you, that was rather confusing, because blame-free means what? That we're not holding individuals accountable? We've really moved from that, and I'll talk a little bit about just culture in a few minutes, but I want you to know that it's not really non-punitive. It's not really blame-free, in my mind. It's really shared accountability. And this shared accountability is between what's called the sharp end and the blunt end. The sharp end, and as Kate said, we'll teach you some terms if you've not heard of these. The sharp end is the care provider who's closest to the patient. So if the medical error is to happen at the sharp end, it's really at the care provider closest to the patient. The blunt end is us and all of you. Blunt end is administration. It's truly leadership. And so decisions are made at both ends. In a shared accountability structure, when you're looking for who's responsible for an error or a good outcome, we have to share this. For every error that ever occurs in any organization I've worked in, if I'm the blunt end and I'm leadership, I am equally responsible for that error as the person who actually had the last opportunity to stop it. That's a different attitude. When we approach caregivers with how did we make that error versus how did you, that's shared accountability. So from blame-free, I would really look at this middle ground, which is how we share that responsibility. Now there's a couple of other terms up here, and I just wanted to make sure that you understood them. Active error and latent error. Active error truly is at the sharp end. How do we correct active errors? One of the best ways is with checklists. I'm from Michigan, so many of you may know about the Keystone Michigan Quality Initiatives, actually borrowed from Hopkins and partnered with them. 70 of our hospitals participated right away in central line infection reduction. The key to saving hundreds of lives, and I have to tell you, millions of dollars in Michigan we saved, and it was about checklists. So from an active error standpoint, checklist is a great solution. On the latent standpoint, that's organizational design, that's decision making, that's leadership. What do we do to fix that? No response? Well, part of that is to get input from the front end, not to just write procedures that we don't get their input and understand, are they going to work? And when you're looking at system design, that kind of takes us to the next one, which is systems thinking, which really has to do with looking at human error and human factors. I'll just give you an example of human factors. How many of you remember, well, you didn't drive here today, but when you drove to the airport or to get here, how many of you remember putting your foot on the brake to put the car in reverse? Raise your hand if you remember doing that. Is anybody driving a car older than, say, 1995? Okay, then you all did it. That's a human factors design. Do you know why you have to have your foot on the brake before you can put the car in reverse? It's so it doesn't lurch out the back without you being prepared and run somebody over that's in the driveway or take down the garage door. That's a human factor design, because humans forget that our foot ought to be on the brake before we put it in reverse. Okay, so when you think of systems thinking, think about healthcare. How do we design systems, forced functions, to be safer? And we have some forced functions now. I want to talk a little bit about evidence-based standards, and I'm clearly going to tell you that I think all of us are hearing evidence-based medicine, evidence-based standards. Some would call those best practices, right? Okay. Sometimes we consider these because we need to decrease variation. Ever heard that? Evidence-based standards are all about decreasing variation. And what about outcomes? Can we predict outcomes if we use evidence-based standards? Well, I just gave you an example in Michigan where clearly the outcomes were incredible. We really saved lives by just using evidence-based standards. And that checklist only had 3 components. And then what about cost? Do you think we can control cost? We can predict costs better or understand both the cost of caring for patients as well as our revenue if we use evidence-based standards? We can. And then lastly, what do the payers expect? Not only our government, but all commercial payers. They expect us to use evidence-based standards today. So I want to give you an example quickly of each of these. And first is, I'm going to talk to you a little bit about how do you define a best practice. The example I'll give you is aspirin. Did you know that if you're having symptoms of a heart attack, or a loved one is, or you come into the ER, one of the first things we're going to do is give you an aspirin. How many of you knew that? Yeah, we've been tracking that, right? Do you know how good we are at giving that aspirin? How good do you think we are in the United States at getting that aspirin in? We're good. I mean, we're like 99 to 100%, really, really good. So that's an evidence-based standard. There's proof that if we do that and do it quickly, we're going to have less blood clot formation. Now, the whole thing about, and I won't get too clinical here, the whole thing about having an infarction, a myocardial infarction, is that the blood clot is actually stopping blood flow to the muscle. You've heard the term time is muscle? Oh yes, that's part of the aspirin. Let me talk to you a little bit about variation. Why do we want to drive it down? Do you think just giving the aspirin is the key, or does it make a difference as to whether we give the aspirin with water and just tell the patient to swallow it, or we tell the patient to chew it? Really? You think that's going to make a big difference? Chew or swallow? How many raise your hand? Any difference there? All right, well, some of you have been reading the detail. It's a big difference. Time is muscle. It can be anywhere between 10 minutes, 8 to 10 minutes difference. If we chew it, the blood clot formation will decrease. The platelets can't accumulate as fast within 4 to 5 minutes. If we swallow it, we're 10 to 12. Let's see, if I calculate that, that's somewhere between, 6 and 8 minutes. What does muscle damage to the heart do in 6 to 8 minutes? If it's my heart, please tell me to chew it. So why do we need to drive down variation? Do you think we're telling patients to chew it 100%? Are we being paid to tell our patients to chew it? So have we totally driven down variation? Not totally. We're getting closer. But I got a feeling all of you will go back and say, are we chewing those aspirins or are we swallowing? Okay, so outcomes. Clearly, can we predict outcomes with evidence-based standards? We can. I just explained to you the physiology, more or less, of why the aspirin must be chewed. So we can predict the outcome. The outcome is not going to be as good, though, if we're swallowing it. We're going to have muscle damage. What's the impact, then, going to be on length of stay and future interventions for that patient? All around swallow or chew. If you get nothing out of this presentation, I know you're going to leave here thinking, let's see, swallow or chew? We're all going to remember that one. And then what about the cost? If you look at the overall cost, this is something that came out of Moody's. Moody's had a report in 2012 that said healthcare revenues on the decline. Profitability is going to be tough. They gave us a negative outlook. There was one thing in their report that they said was common for hospitals that are going to achieve and do well financially. Guess what it was? Standardization. Drive down variation. So if you think you've heard that word enough, you haven't. This is really the way of the future. And lastly, when you look at payers, I just wanted to comment to you a little bit on medical tourism. Pretty interesting. How many of you are familiar with medical tourism in the U.S.? Yeah, quite a few of you. I'll tell you a quick story about Walmart. Walmart has about 1 million employees, and Walmart did a study, and they said, you know what? We can get better care, better quality and outcomes for our patients, and lower cost for them and for us if we actually fly them and even a family member to where we see in the United States that they can get the best possible care. Walmart did their homework. They identified 6 or 7 organizations for hearts, for joint replacements, all kinds of high-cost procedures. They started this in January, and Walmart employees have a big deductible. Some of them can have up to $5,000 deductible. So even the patient, if they will use the medical tourism process that Walmart put into place, they will waive part of their deductible. How many Walmart employees do you think are flying across the country today for their health care? A significant amount. And what do you think is happening with their quality? Quality's going up. What do you think is happening with Walmart's costs? It's early, but they're already trending down. Okay, so it's working for Walmart. Who's next? Home Depot's in line. There's many organizations that are looking at the same process. Do you think they're only looking in the U.S.? No. Medical tourism is huge globally. I travel the country in many organizations, and I was in South Korea recently. South Korea really touts themselves as having the best outcomes for spinal surgery, and indeed they may. So they're really rising now in regards to recruiting that high-risk area for spinal surgery. So when you look at evidence-based standards, and then you kind of look at another challenge around patient safety, I wanted to talk to you just briefly about workforce and recruitment, and I'll give you some quick stats here. We have 3.4 million direct care workers in the U.S. today. We need 4.8 by 2018. What do you think about that? Job opportunities in healthcare? Yeah, maybe, although aren't we beginning to see some shrinkage? But where do you think these positions are going to be? They're going to be in the hospital? Outpatient, absolutely. So sometimes people see these stats and they don't believe it, because in the hospitals we're feeling a lot of pressure right now, shrinkage of positions, not growth. The growth of these positions is going to be in the ambulatory setting. We have 40 million people over the age of 65 in the year 2010. We're going to have 75 million by 2030. That's a pretty big growth, don't you think? What does that mean for healthcare? Are we looking at this kind of data when we're preparing? Our nurse positions are 2.74 million in 2010. We'll need 3.45 million in 2020, up 26%. And guess what? I'm looking a little older than most in the room, but I think I'm going to need health care by 2020, and some of you are not going to be much after me. We have an incredible, I would say, challenge around nurse positions in just a few years. And then lastly, look at our physician shortage. 63,000 by 2015, 130,000 by 2025. So clearly, it's going to be at the nurse level. And where are the positions really increasing? They're at the nurse level. Nurse practitioners, physician assistants, it's our advanced practice nurses that those positions are clearly going to continue to grow. The last thing I'll talk to you about is kind of data mining, because at the center of everything the three of us are going to talk about is data analytics and data mining. This isn't going to work for any of our organizations if we don't get our arms around the data. And before I talk to you about data, I just want to give you a quick example. Data is really about business intelligence. Have you heard that term? Some have. Let me give you an example. Sometimes it's easier to give an example than to give you a definition. In the opening, you saw all the books, right? And Susan talked about Amazon. Well, after I heard Dr. Macri speak yesterday, I said, yeah, you know what, now I really want to read his book. So I went out to Amazon, and I went to find Unaccountable, and there it is. And I got to tell you, this just amazes me. Amazon knows me better than I know myself, because up popped 3 more books that they said, based on what you've ordered in the past year, we know you like this kind of reading, and you shouldn't just order Unaccountable, but you should order the other 3. That's business intelligence. They've been tracking me, and they're right. They do know me better than I know myself. How many books did I buy? Oh, it's all over the place. 2. I limit myself to 2 every time Amazon pops up, because I'm reading 6 books at a time, and I know if I order all 4 of those, even though they're right, I'm not going to be able to get it done. So I want you to be thinking about business intelligence. What does Amazon know about me? What do you know about your patients? When you look at population health management, which is truly where healthcare is going, we're going to be managing by zip codes. So I'm in a zip code, and my doctor now has a medical home, and he's responsible in some ways for me, both prevention and care. He's got to know a lot about me, so let's talk a little bit about that. Do we know now how to target poor performers? Can you do that internally? Can we do it rapidly? We're getting better. Kate's actually going to tell you about how you can go out to the internet and target poor performers. My mom, who's a retired nurse, got ready to have double knee surgery. She went out to Hospital Compare, Rates MD, all kinds of areas. She brought me all her data, all her literature, and said, I think I should go here, and I think I should avoid this doctor. Interesting, huh? And what about targeting costly conditions? Do we know how to target the costly conditions? All right, let's just quickly go through and look and see if we know. What are the conditions that cost more than $50 billion a year to care for in the United States? What are they? I'm hearing some things. Emergencies, diabetes. Well, you're right. I'm going to quickly give you these stats because I just found them absolutely interesting, and I'm not positive I could memorize them all. Okay, so the first one is heart conditions. That's $107 billion. Injuries, accidents, $82 billion. Cancer, $81 billion. Mental health disorders, $73 billion. Asthma, $63 billion. Joint disorders, $62 billion. And diabetes, $53 billion. So we know it's costing a lot. And let's just, for a second, talk about joint replacements. Some $60 billion a year, right? We're doing about 1 million joint replacements per year today. By 2020, they anticipate we'll be doing 4 million joint replacements per year. What's the cost of a joint replacement? How many workers, let's look at this differently. How many workers do we need today for each joint replacement? Anybody have an idea? She wants to know if that's short-term or long-term workers. Let me put it in another way to frame this. In 1960, we needed 3 workers for every Medicare recipient. Today, we need 13. So you kind of see what's happening to us. Were we doing this amount of joint replacements in 1960? No. How many workers are we going to need in 2020 to keep up with our joint replacements? Some anticipate that number is between 15 and 20. Do we have that many coming up to take care of the boomers' needs? Possibly not. So targeting the costly population, I'll just tell you quickly here, we know, we have this data. American Hospital Association published this, probably 18 to 24 months ago. We spend $300 billion in the United States on 9 million people. Okay, 9 million. 1.6 million of the 9 million actually accrue 70% of the cost. If the 1.6 million are in your population, your zip code that you're managing, you're going to be responsible for them, whether you have an upside or a downside financially. Do you know who those 1.6 million are? Many hospitals today that are truly using data analytics, we know. We know exactly who they are. And we're reaching out. We need them not to come into the acute care setting, to stop using the emergency room, to stop the continued readmissions, because this is a heavy population that's utilizing those services. I don't have time to tell you about the solutions, but there are a lot of solutions in play today about how are we managing the 1.6 million and still being able to be financially strong. And then can we predict for shared savings? We can, and Susan's going to talk about that, so I'm going to kind of leave that for her. And then lastly, the value-based purchasing, the bonus and penalty, all of that is wrapped around data. And before I pass it to Kate to talk to you about transparency, I'll just leave you with one thought. We got our checks, or our debit, not too long ago. There were 3,000 hospitals that were actually in the database that participated. Do you know the percentage that got a bonus versus a penalty? Anybody know how many hospitals of the 3,000 got a bonus? 1,400. What's that mean about the rest? Is that at some point going to be directly related to our sustainability, whether our organizations can financially make it? We're talking about a 2% bonus. 2% can actually be our overall cost margin in a hospital. So if we're losing that or leaving it on the table, that could be the difference between making it and not. So with that, Kate, I'm going to pass it to you to talk a little bit about transparency.
Great. So what is transparency? I know you hear this all the time. What does that mean to you? What does that word mean to you? You know what it says to me? It keeps us honest. It's honesty. So when you're communicating with physicians, I know they hate this. You know, they look at Hospital Compare. You all look at that once in a while, don't you? Do you look at your own hospital? You should. See, doctors find this as government interference. This is what they say. Oh, this is the government looking at us. Well, you know, the government's the largest purchaser of health care. Why wouldn't they expect that it would be transparent, you know, how a hospital performs? How many here know what the health grades are? Have you looked at health grades? Good. Do you all know what your leapfrog score is? It's fine if you don't. We're just trying to, when you go back, find your quality VP director and see what your score is. Leapfrog's giving everybody a grade now. How about if you're part of the system? I'm part of HCA. They share a wealth of information. We are transparent from the hospital to our division to our corporation and vice versa. That information comes down. So I know how every hospital is performing in our enterprise. So physician reporting is the future. And here's where you need to be communicating with doctors. You know, and I say this all the time. You're like a counselor to physicians. They're in your office, and they're grumbling, and you're listening to it. And that's awesome, because they need that. But now you need to help turn their mindset. Don't just let them leave after they've grumbled. Educate yourself about some of this stuff so you can help them. You're going to have to help them make this transition. So when we talk about physician profiling, sorry, you guys have to hit the button. They need to go out and look at health grades. They need to look at all of these things. Tell your doctors to Google themselves. You should always Google yourself. Because whether it's validated or not, we have now brought in, as Susan's going to talk about with HCAPS, value-based purchasing, the perception of a patient and how they're treated as a human being. So these doctors will say, yeah, well, I'm one of the best surgeons in the world. Well, if you don't treat a patient nice, you're not going to get a good report out there. How many of us shop for hotels and we are influenced by what the comments are of people that have stayed there. Same concept. So Susan's going to tell us everything you need to know about value-based purchasing. You know, you've heard the term, right? Well, Susan's an expert, so she's going to give you some very good information about that.
Oh my goodness. Thank you. Affordable Care Act, Obamacare. How many of you have been bombarded with news reports about that? Okay, yeah, we've all been hearing about that. But did you, and it's very controversial, we're not going to talk about the mandate for individual insurance coverage and how all that's rolling out in the insurance exchanges. But did you know that there's a good portion of the Affordable Care Act that relates to quality of care and how we're realigning incentives around quality of care metrics and outcomes? So it will not be how much you do, but how good you do or what your performance is. I was researching for this presentation. I found an excellent summary done by the Institute of Medicine. And if you're taking notes, it's called the ACA Provisions with Implications for a Learning Healthcare System. It takes those thousands of pages of the Affordable Care Act and reduces down a great summary of what the quality-related provisions of that act are. And this would be a great document to share with your physicians. It talks about how these provisions extend not just to the hospital and hospital compare that Kate just talked about, but also the Physician Quality Reporting Initiative, which is going to bring a great level of transparency to how physicians are measured and compared. And right now they're being reimbursed or given a bonus for reporting into that system. But what's going to happen? Ultimately, just like what happened with hospitals and hospital compare, it's going to go from incentive for reporting to incentive for performance, so that physicians will be receiving greater reimbursement based on how good they do. Hospitals are already being reimbursed at a greater level for higher quality and better outcomes. And there's reduced payment for potentially unavoidable readmissions, for healthcare acquired conditions, for complications, and so on. The Act also requires a national improvement strategy, and a new commission is being set up to manage that initiative and that strategy. Another big thrust of the Affordable Care Act is fraud elimination, and we're going to see a greater emphasis on looking at medical necessity and addressing that. And then transparency, what Kate just talked about. There's not going to be just the Hospital Compare website, which I hope you all have looked at for your own facility and how you compare as an organization, but there'll be the Physician Compare website where we can all do the same for the physicians that we're selecting. You've heard of HCAHPS, no doubt, if you're in the hospital setting. For those of you who are not, this is a measurement system. It started with long-term care, actually, and it measures not patient satisfaction, but the patient experience on these 8 domains of performance. It's about the behavior of the entire team and how the team is performing, as well as the facilities and the environment of care that's being created. We might think about these 8 parameters and how they relate to the core competencies that Joint Commission talks about and how we should be assessing providers before we credential them, in the parameters of 6 competencies that we look at in getting peer evaluations, and also in how we're doing our ongoing professional practice evaluations and focused professional practice evaluations. Think about how you might build in an early warning system into the credentialing process, so that if you have a practitioner who's coming to you with an application, you already are seeing a lot of information about adverse actions related to communication difficulties, related to behavior and conduct, and so on. Think about how this is going to impact you. we're going to get to the point, the parameters of being in the top percentile, where you're getting that incentive for good performance, is achieving almost 99, 100% on some of the measures. So you bring a new practitioner in who is got a problem with performance in these areas. What do you think that's going to do to your organization's ability to stay in that top tier and get those incentives? Because it takes very little in numbers of cases to pull you out of that top tier. So we're going to need to start thinking about that and who we partner with and what sort of evidence of competencies related to interpersonal skills and communication skills that we're looking for in a team member that we're going to bring on board through the medical staff credentialing process. And then, do you think all physicians that you already have on staff are doing great in this area? I'm seeing a lot of head shaking. Yeah. How many have the Dr. Retro scenario in your hospital or your organization right now? And relate to that. So how do we help our physicians? How do we help our nurse practitioners, our PAs, and all the others that we credential to be better performers in this area, to be stellar performers in this area, and helping us do well as it relates to HCAHPS and the 8 domains of performance? Are you bringing in education? Have you set up a physician support network? Do you have mentors? Do physicians know that the organization is being measured in these areas? Do they know what the scores look like? And these could all be strategies to raise awareness, help them understand what role they play in this, and help them achieve better performance. Tier and steer. This is a strategy many of the major health insurance companies are using. If you're insured, you may start to see when you go and select a new physician. My health plan does this already, where if I'm going in and looking for a new physician, and I go to their online physician roster, some of the physicians on that roster have little gold stars. And why are they getting gold stars? Well, because according to the insurance company's records, these are the physicians that have the highest quality and the lowest cost. They have greater efficiencies, whatever the parameters are. So with the little gold stars, they're trying to influence my decision. As an uninformed, average healthcare provider is not going to be like Kate's mom or Michelle's mom and go out and do that research. They're going to look at something like that and say, well, I want one with the gold star, right? So physicians are going to start to see their new referrals being influenced by this. The other way that insurance providers are going to influence the consumer and who is getting patient volume will be through the copays. So they may take all the providers in the roster and rank them, and the top ranked tier, the high performers, the consumer will be given a lower copay or incentives for using providers in that tier, and they may have to pay more or higher copay if they use somebody on the lower tier. So this will create some disincentives. There'll be greater transparency, and choices will be driven this way. So I've also been hearing about accountable care organizations. And these are groups of providers. It's going to be physicians, hospitals, post-acute, physician groups who voluntarily come together to coordinate on that population of patients they've been assigned to in keeping costs down and quality high. They'll be measured on a number of parameters related to outcomes and process of care and there will be incentives built into the reimbursement for the accountable care organization to do better with that assigned patient population. How many of your organizations are looking at an ACO or already part of an ACO? Okay, so number of hands going up. Has that changed your approach to how you're credentialing? Has anybody talked to you about, who should we be including in our ACO arrangement? Do we want just everybody who's currently on the medical staff to be part of the ACO? Because it's an all-in. Once you form this ACO, the incentives that are going to be awarded for the great performance of the ACO will hinge on the performance of everyone. So you heard it from Michelle, what are those high-cost DRGs or the high-cost diagnoses that are out there? Did you hear from that many of them are chronic care type of conditions? The CHF and heart conditions, diabetes. These are types of healthcare conditions that will require care across the entire continuum. And if an ACO takes on patients with these sort of conditions, it's going to be performance across the outpatient, post-acute, inpatient that will determine how they're awarded. So they'll be accepting risk-based reimbursement for managing this entire patient population. The better they do, the more profitable the arrangement will be. They're also at risk of losing money if they don't manage well. So ACOs will need to be very selective in who they partner with, and poor performance will affect everyone within the ACO. It's going to be advancing this goal towards lower cost and higher quality, which is where we all need to head. So we've talked about 4 models of how we share risk and how we incentivize better performance. The bonus payment, the value-based purchasing, the better you do, the more you get paid. The market share risk, the tier and steer, revenue based on a baseline of performance. This is going to be core measures, HCAHPS, how you're performing on readmissions, healthcare acquired conditions, and then finally the financial risk for patient population as a whole, and that's going to be the ACOs. So how much does this really encompass? The studies have shown a 3 to 5% impact on healthcare institutions' revenue, taking all of these types of risk-sharing arrangements into consideration, and how it will drive cost out of the system. Any guess on the total amount of dollars that might represent? $39 billion with a B of revenue decrease based on these 4 strategies. So where's this all going to go? We're kind of hearing a combination of these strategies being used now. This graph shows a prediction. It was by the advisory group that shows reimbursement is going to continue to shift. We're not going to be stopping where we are now. The shift will be going from pay for performance to more of an ACO model, that population management model, and that within 10 years of the entire implementation, 70% of reimbursement will be at risk based on how well you're doing in population management. So it's going to make it more of an imperative and really a matter of survival for your organizations to pick the right partners to promote and support best performance. And the ACO model, it's going to be critical to have great credentialing processes, great processes for awarding the right privileges, and having a very strong database of performance and support of physicians and credential providers in how do we get them to perform at a higher level, and how do we get them to do well. So we want to spend some time in talking about how quality departments, risk management, medical staff services, how can we work together better? Now, we started, and if you think about it, how do we end up in different departments anyway? Well, about 100 years ago, not really, more than maybe 25 years ago, Joint Commission started off with standards that had a different chapter. There was how many of you can remember, a QA chapter, a utilization review chapter, an infection control chapter, right? So what did we do? And this is in the hospitals. We all went out and created a separate department for each of those chapters, and everybody got their own chapter to worry about. We had a director for each department, and we pretty much stayed siloed. Everybody took care of their own function. Well, the picture we've just painted for you about where this is all headed with different alignment of reimbursement, of how better quality is going to be incentivized, of how we're going to be responsible for managing entire populations, about how all of this is going to be much more transparent, and providers and consumers are going to be using this data to pick really the winners and where they're going to want to go and get their health care. All of this is saying we can no longer sustain this siloed model. We can't stay in our own departments and be successful. We're all going to need to become adept at knowing what the areas of opportunity for improvement are, and work together and be really great at managing our data and supporting our providers and becoming better. So we want to take what looks like a rather daunting challenge right now and turn that into an exciting opportunity. But it's going to take a huge amount of communication, teamwork, and embracing change. So we want to spend a few moments talking about what have we done so far. NAMS has been a great partner with NACU. We have partnered on something that both organizations are very proud of. It was the NACU Call to Action. It's titled Safeguarding the Integrity of Healthcare Quality and Safety Systems. We came together after hearing news reports about and hearing studies about how quality issues and concerns are not being brought to the forefront. They were not being reported. There might have been some inaccuracies in quality data being reported because people didn't want to bring things out in their organizations. We heard from our own members in NACU, 3 out of 4 of our NACU leaders said they had personally experienced an incident related to reporting of quality data or incidents. We had a study showing 40% of clinicians keep quiet or remain passive to avoid possible reprisals when they're seeing something go wrong. That was done by ISMP. And then there was a study published by JAMA in which physicians were surveyed, and 1 in 3 of the physicians who were surveyed said they failed to report impairment or incompetence issues because they were fearful of the reprisals. We heard about the case down in Texas, in Winkler, Texas, of the 2 quality professionals who were fired from their job and actually arrested for reporting a physician to the Texas State Board of Medicine for some of the things he was doing with patients. He later was investigated by the board and lost his license. But last we heard they were still without jobs, those 2 quality professionals. And so what is that saying about a patient safety culture in which there's people don't have to be afraid of reporting concerns, and the concerns will be dealt with appropriately and managed appropriately, and the patient safety upheld. So this call to action pulled together a group. It was AMA, AONE, AHIMA, APIC, ASHRM, our partner Michelle, the American College of Physician Executives, Joint Commission, we had somebody there from CMS, the National Patient Safety Foundation, and the American Health Lawyers Association came together, and there were 4 key recommendations there. Number 1, establishing accountability. Number 2, protecting reporters. Those who are reporting concerns need to be protected. Number 3, ensuring that quality data and incidents are reported accurately. We can't manage what we can't measure. If we don't know what the concerns are, we're never going to be able to address them and fix them. So we can't have fear keeping us from knowing what's going on. And then finally, responding to quality and safety concerns quickly and appropriately. And we feel this is vital for moving ahead. The other thing that we're focusing on with in the quality arena is medical necessity. You know that Medicare pays for medical items and services based on them being reasonable and necessary, and they have a variety of ways of figuring out what that is. There's the laws in place that prevent a provider from turning in claims and asking for reimbursement for things that were not medically necessary. And we are seeing increased examples of liability under the False Claims Act occurring. There's a session right after this where we're talking about this in particular to cardiac care. And we're seeing it also with back surgeries and some of the orthopedic procedures that are being done. So this is an area that we want to focus on. So I'm going to turn it back over to Michelle, and she's going to talk about enterprise risk management.
Thank you, Susan. Remember how Susan just talked about those silos? At least that's what I would say they are. The Joint Commission came out with each of those chapters, and we all set up those departments. Were those not silos? Are we still siloed? Yeah, pretty much we are. Well, this is a huge initiative and a huge role of the risk manager, and that's what's called enterprise risk management. So when you look at how we, as partners and as departments, really work together, part of that is to break down the silos, and that's enterprise risk management. So I want to just share with you Ashram's definition, and basically what enterprise risk management is, it's a framework. And this framework is really about how we make risk management decisions which are going to maximize both value protection and value creation by managing risk and uncertainty and the connection to total value. Now, I'm sure you're all sitting there going, what the heck did she just say? So let me just break that down for you now. That's what we do. We manage uncertainty. Risk is uncertain. We don't know exactly what's going to occur. We do know, based on chewing or swallowing an aspirin, the potential likelihood of certain risk, correct? So we can predict some of the time. But a lot of times, really what we do, we manage the uncertainty. And when you look at value protection and value creation, let me talk just a little bit about that. First, what's value? Value is defined really broad. Value is our assets, it's our people, it's our workforce, it's our patients, it's our finances. So I want you to see value as this great big bucket of everything that we do. So we're trying to protect our value. We're trying to protect our patients from harm. We're trying to protect our organization from financial loss. And then on the other side of that is value creation. Now, risk managers historically were really, our field came out of the malpractice crisis in the 70s, and it was all about value protection. Protect our organizations from financial loss control. We have evolved, just like every other entity. And today, really, we're spending almost as much time in value creation as we are value protection. If we don't help our organizations create value, all those things I just talked about, our organizations are going to have a hard time sustaining in the future. We just saw Susan's graph that said 70% of all revenues will be pretty much total cost, risk sharing. So we have to figure out, how do we help our organizations create value? So there are several domains, and as you'll see in these circles, these are the enterprise risk management domains, and the whole focus of this is to get out of the silo. Enterprise risk management is the big picture over everything that we do within our organizations, including other industries. Do you think the banking industry had a great ERM structure? What do you think? They actually had an ERM structure. They didn't follow it. So not only do you have to have a structure in place, you have to use it and you have to follow it. So I'm not going to go through each of these domains. You guys can read them, but as you can see, it's from operations, it's your strategy, it's looking at your financials, it's the clinical, it's the quality, it's hazard and environmental issues, it's technology, legal, regulatory, all the way down. And as you can see, I have all of these pointing to patient safety, because patient safety is at the center, really, of everything that we're doing. So I want to kind of bring this alive to you around this value protection and value creation, and I'm going to ask you a question. How many of you are purchasing, your organizations, purchasing physician practices today? Raise your hand. Okay, this is a really good one then. We're purchasing physician practices. Do you see where we might have to protect our value when we do that? And do you also see where we actually might be able to create value for our organization? Do you see this on both sides? Okay, so let's just take one domain. Let's take the financial domain. What might be the upside? And this is another way to look at value protection, the downside of what could happen, and value creation, the upside of what could happen. So let's take a look at both right now. On the financial end, just that domain. What's the upside? Increase patient volume. Ultimately what? Increase market share? Increase our revenues. There could be a huge upside. Do you think that we might do a better job actually achieving pay for performance? Do you think we might have a better opportunity in creating our ACO integrated networks by having these practices within our realm? So there's a huge upside, right? Okay, if the risk manager was only looking at the protection side or the downside, then we might say, oh my gosh, no, we did this. Remember, 15 years ago we employed them all, and then we decided that wasn't such a good process and we should undo it? Well, we could still be thinking there, but that would be very short-sighted. There is some downside. What might be the downside of buying these practices? It's costly. Yeah, if we do it the same way we did it 10, 15 years ago, I don't know if that's going to work for us. There also may be some issues around their infrastructure. Do they have an infrastructure of that practice that we're purchasing? Are we doing due diligence? How are they billing? You heard Susan talk about billing issues and fraud, right? What if they're intentionally, or maybe not intentionally, committing fraud? Does that now roll up to us? Yeah, as a risk manager, I'm going to look at the upside and the downside. So when we're about to go buy a practice, I'm going to look at my medical staff process in regards to credentialing and everything that you're doing on that end, and I'm also going to be looking at many other areas. The government says that they believe there's $75 billion of fraud that they have not recovered yet. They're increasing their resources, of course, to take a look at that. So there's going to be a big challenge. That's definitely on my radar when I'm looking at employing practices, purchasing practices. Let's take one more domain. I'm going to watch our time here. I think we have enough time to do this. It's only going to be about 1 to 2 minutes, but it's always good when you come to something that you get to talk to each other for just a second. So I want you to look at your neighbor, and it's dangerous when I give this to the audience to get you back. So when I raise my hand and try to get you back, please do come back. I want you to take one more domain, just like what I did, and talk about the upside and the downside from your view, and not just your view and your role, but the big picture. So take 1 or 2 minutes and see if you guys can identify one of those domains, whether it's legal, regulatory, whether it's related to what you do. Okay, go. Okay, now I know you're thinking, you just started this great conversation, and some of you are looking at me like, really? We just started this. Are you truly stopping us? So here's the challenge. Remember when I said to you it's so dangerous when I give the room to you to try to get it back? You guys have a lot to talk about, and I think you clearly get the idea of the upside and the downside of enterprise risk management. So I'm going to challenge you to find your partner during lunch to try to sit together and finish this conversation. Because if I don't bring you back up to us, the three of us won't be able to get done. So anyway, I wanted to just kind of give you the feel of what that looks like. Pretty good, she says. All right, the next thing that I want to leave with you is just, as Susan shared some of the initiatives by NACU, I want to share just a little bit in regards to what ASHRM's doing as well. ASHRM's annual conference, just like yours, is just a few weeks away, and our theme this year is Everyone is a Risk Manager. Just like I said to you, everyone's responsibility is patient safety. Everyone's a risk manager. You guys can also use the framework of enterprise risk management. And when you do your medical staff role, if you really think about all those domains and how does this role have an impact on the bigger organization, then healthcare is going to do really well. And we'll show Moody that they're wrong, that it's not a negative outlook, that it would be quite positive. One of the things that ASHRM did in 2011 was start an initiative called Getting to Zero. And this Getting to Zero actually is about preventable harm. It's really eliminating what we call preventable harm. Now that word preventable is really key, and I would encourage you to go out to the ASHRM website. We are publishing white papers on serious safety events. The first one is out, which actually defines what a serious safety event is. The second one is in works now. We're creating a classification system that will help organizations truly classify what is considered preventable harm based on deviation. And this is going to separate out the complications. So you know how you're doing peer review? You're always looking at this. Is this a complication or is this really preventable harm? We believe that this definition and this classification is going to help your roles enormously. And with that, I want to pass it to Kate now to talk a little bit about proactive peer review.
Thank you. So next key concept that involves you directly, because I know many of you are involved in peer review. We've got to get to a point of peer review as we know it no longer exists. So I want you to write down clinical excellence, because we're going to talk about clinical excellence through this whole thing. That's going to be one of your takeaways, and equate that to proactive peer review. Our risk department and the quality department would sleep much better at night if they knew that you were spending time trying to educate doctors. Again, we're going back to best practices and utilizing time rather than waiting for something bad to happen to a patient, and then you all sit in a room and decide what happened. Those things will happen. There will always be a root cause analysis because we're human beings taking care of humans. We will not move off this dime until physicians understand, just like Dr. McCary was saying, and use those examples that he used in his presentation. Doctors can learn from each other and these best practices. So how many here have clinical excellence programs going on right now? They may look like an Aim for Zero campaign. We're never going to have another central line infection. You've heard this at least. How many have something like surviving sepsis? Sepsis is very deadly and can be prevented if you do the right things. Okay, that's what that is. So we want to look at physicians' compliance and understanding of a best practice. These are protocols, these are order sets. And this is where you need to increase your knowledge about these tools and start talking to your physicians about using them and what they're for, because this is, again, this is the way of the future. This will, if we move to proactive peer review, what are we doing? We're essentially just trying to prevent things from happening. We've done it in the OR effectively. We take a time out, we mark the surgical site. We're starting to see those horrific events that have happened decline, but we've got to do this in every facet of healthcare when it comes to physicians and how they look at themselves. So you got to monitor that best practice, monitor their compliance to it. So this is a huge takeaway that I want you to think about when you go back and look at your peer review program. We all have antiquated peer review. Let the doctors do their M&Ms. Like I said, it'll happen. Let the doctors do that very classic, M&M review. They like to do that. But try to change that boat when it comes to peer review. We've done some of that. So more strategies that we can work on together that are going to involve you a little more directly. So how many of you either prepare a report for your chief of staff? How many have a chief of staff that go to, I'm talking to hospitals primarily here, that go to the board? Okay. Then what do they present on there? Credentialing. Reappointments, appointments, change in privileges. Talk to the chief, find out who on the board or what type of quality information is being collected. There's tons of it. So again, get to your quality department. Start getting that information about quality of physicians, results of peer review, and start getting that in that report. Because the chief of staff or physicians that sit on your board are huge to get. That's the engagement at the board level. And be bold. Go to your CEO, go to the C-suite and say, let me see the agenda for the board. What else do you all talk about? Some of you may sit at the board meeting. If quality is not at the top, right now it's probably finance, it's operations, lay of the land, what's going on in the community, what's going on in competition. You've got to get your voice out there too to say, let's get quality up to the top of that agenda. So get involved in the C-suite for sure. Educate, educate, educate. We just talked about just culture. We're going to actually give you what that definition is and what that looks like. The human factors, again, physicians are human beings. You've got to understand all this just culture so that you can communicate it well. And again, it's, like I said, they've got your ear. They listen to you. The more you learn about this and can project back to them is going to be key to get through this tsunami. So I think next up, Michelle, you're going to talk about just culture. Just to give you hear that term a lot. She's going to give you some real practical examples of what that really means.
How many of you have heard of just culture? Raise your hand. Okay, quite a few of you have. So the next couple slides I'm going to go through quickly, and I'm not going to follow them exactly, but let me just tell you in my own words what a just culture is. Very simply, it's the middle ground between punitive and non-punitive. So as I said earlier, it's not about blame-free. It truly is looking at shared accountability. So back again at the sharp end and the blunt end. The next slide actually is talking about some of the patient safety culture components around behavior, whether it's human error, whether it's negligence, reckless conduct, or knowing violations. How many of you think negligence means that there was intent to do wrong? It does not. It means we didn't do what another reasonable person would. And so if you look at David Marks' work, many of you familiar with David Marks? Some are, some not. I really encourage you to go out and to Google David Marks' name and to look at the Just Culture community. You can join the Just Culture community. There's a whole community now. Regular information will come out to you. David has made this very simple, that there are 3 behaviors. And I would encourage you to consider the Just Culture components in the peer review process. Many still consider peer review, especially our physicians, as punitive, as a scary process, not really a place for learning. So if you look at the 3 behaviors that David Marks talks about, it's normal error, it's at-risk behavior, and it's reckless. Okay, so you think about it in those 3 areas. We all classify peer review outcomes with numbers or letters and all those things. If we begin to look at all complications error in this particular realm, in these 3 buckets, normal error just happened. We couldn't see it coming. It just occurred. In the middle is at risk. 70% of all medical error is in the middle. It's at risk. We think we're in a safe zone, but we're not. I'm a nurse. We've done workarounds. I've done workarounds because I didn't have exactly the equipment that I needed, or that I really thought I could do it better this way rather than how somebody in the C-suite wrote a 30-page procedure that I can't follow all of those steps. So this workaround is the way to get my job done. So I really do think I'm safe. There's no intent to do harm. That's where the majority of error is. And reckless is over here. Reckless is very small amount. Healthcare providers don't go to work every day and say, okay, well, I'm not going to follow policy and procedure. I'm going to just knowingly violate, and I'm going to do what I think is best. I'm going to be reckless. Reckless can also be criminal, and we've had some of those situations. So I encourage you to think about error in those particular buckets and look at, can we incorporate the just culture into the peer review process? I think it'll change what it looks like today if we do that. Yeah, she's got a great point. For those of you that didn't hear, she's talking about Silence Kills. It's a great article. If you've not read that, go out and take a look at that. The other thing she's commenting on is the ability to speak up. There was a study that was done in March of this year by GE and the American Nurses Association. 64% of nurses still say today They're not comfortable speaking up for the fear of punishment or retaliation. So clearly, we have work to do. I'm going to go ahead now and just pass this to Susan to talk just for a second about clinical excellence.
Thanks, Michelle. This slide provides you with some of the steps of what I'm talking about with clinical excellence. As a strategy, it means raising awareness among physicians. Physicians typically care for patients one by one. They think about what will cause a better outcome from their patient based on past experiences with their patients. We want them to start looking at what's best based on evidence-based medicine and look and compare how their pattern of practice is turning out, what's been achieved versus what's possible, and substantiate that with valid research results. Then examine the performance gap, be intimately involved in the redesign of the care process, agree to those changes in care design, and measure and, of course, celebrate the success. So you might say, well, how is this different than CQI and all those other things we were doing in the past? It's really about engaging physicians right up front. It's the proactive peer review approach that Kate just talked about. It's the data mining that Michelle has talked about. It's bringing all of these things together to improve across an entire patient population. With that, I'm going to turn it back over to Michelle.
Well, the one comment that I wanted to make here, and I don't want to spend a lot of time here, is just the whole code of conduct. We're talking about behavioral expectations, right? How many of you in your organizations actually have a formal medical staff code of conduct that's signed? Look around the room, you guys. I'm really proud of you. 5 years ago, when I asked that question, I got to tell you, not even 10% of the room would raise their hands. So we've really come a long way. You're ready for the next step, which is proactive peer review and incorporate the concepts of just culture. So I don't need to spend time on code of conduct. You guys have mastered that. What I want to do now is really talk with my partners about this team-based approach. And as you can see, I really think often in concepts of three. So I want to talk to you about just kind of this concept of three areas. And that is, first, detection, second, prevention, and third, correction. And these are some high reliability concepts. When I think of detection, I really think about you guys. You detect the issues before they get in. So if you do that well, we may never have to really get to some of the prevention issues. When I look at what quality is doing, quality is very much about preventing defects. And then when I look at correction, that's risk management, using our enterprise risk management to protect value and to create value. So with that, I just want to kind of have my partners chat just a minute about how do they see this relationship. Susan?
Well, I think really getting away from the siloed approach, starting to realize how we can share information and work as a team and recognize how we're all really pulling for the same goals and the same outcomes, and engaging our medical staffs and physicians, I think, are going to be crucial.
Kate, I agree. I think there are many opportunities for the three to come together. You need data. Quality has data. Risk management wants to reduce risk. You can reduce risk by using some of these strategies. And the key is physician engagement in this whole process. And so that's the role that I've always say that you'll play.
So the three of us, as Kate said in the beginning in 2011, said, you know, if the three past presidents of our organizations could come together and begin to talk about breaking down the silos at a very high level within the association, can't we send the message to all of our members of each of our areas to begin to break down the silos in our organizations? That really, the three of us are not only partners today, but clearly we're partners in the work that we do. What we'd like to do now is tell you that that's worked. Pretend the three of us work in the same organization. I can tell you, it would just be amazing. We would definitely be having very positive outcomes. So we'd like to tell you that that's what happened. And we'd like to go back now to the scenario that we started with Dr. Retro. One more.
Well, hey, guys. Well, you're early for the meeting. Oh, God, I can't wait to get to these meetings, Kate. Good.
I guess we're all pretty excited about the announcement this morning. One more national recognition of this hospital as an outstanding provider of care, this time for cardiac care. We can all be pretty proud of that. I can't wait for the committee members to hear about it It seems like one success just leads to another because more people are starting to take pride in their work and feeling good about what we're achieving.
Well, I got to tell you, Susan and Kate, I remember the dark days, which really didn't seem all that long ago. Nobody showed up for these meetings. The physicians didn't participate in decisions. I mean, I dreaded coming to these meetings. And I got to tell you, the environment is so different now. Even Dr. Retro is a pleasure to work with.
I know. Once he was shown that his patients could have a much better surgical outcome with just a few changes, and changes could be hardwired into the system, it was not extra work for him, and he was at least willing to try.
I think what really sold him was the recent data proving that his patients, in fact, did experience fewer infections and readmissions. He was so excited to see his own improvement when his physician mentor met with him.
You know that he even maximized his own efficiencies. He even agreed to take a few classes to learn the new EHR system. Amazing. The issues with his handwriting and delinquent records have disappeared. It really helped after the chair of the surgery department sat down with him to have those crucial conversations we always talked about.
Well, you know, I think it really started for him. He actually confessed to me once that he just felt overwhelmed with the amount of regulations, the pressure around reimbursement, and, you know, really, I think he was fearful about his own capabilities. So I think it started to change for him when he engaged in the new technology, when he began to learn, and he understood his infection rates, the readmission rates, and how this all really connected. I think once we helped him with that and started to work with the medical staff as a whole, the whole process just worked so much better together.
He said it also helped that the hospital started providing him with his own dashboard each quarter so he could see how he compared with other physicians, and he knew who to seek out to learn what steps were key factors to better outcomes. He said the dashboard also made him realize that there were certain surgical procedures that would be best left to other surgeons, so he adjusted his privileges accordingly. While admitting that he was not a believer at first, he's now a big supporter after seeing his own results improve.
Did you see the bulletin board in the doctor's newsletter?
I did.
Dr. Retro started a lunch and learn with some of the younger members of the department, and he even invited the nurses to attend, to participate in the discussion. The other day I walked into the lounge and I saw, look how he's smiling. He was smiling at me, and I said, well, why are you so happy, Dr. Retro? He's like, you know, I got a thank you note. I got a thank you note from the nurses on the unit. We took care of a real difficult patient. And I just felt so appreciated and so welcomed. And I just really want to say that that meant a lot to me. It meant a lot for my family to know I was recognized. So he has completely turned around, and we can all do a better job, I think, based on the work we've done with Dr. Retro and the good work that we've all done together working with the medical staff.
Well, thank you, everybody. We appreciate you attending this session. I think we've only got about 3 or 4 minutes, so I don't know if there's any questions. But the last scenario truly is reality. I'm fortunate enough to work across the country in many hospitals, and I do see this particular outcome. So for those of you that are not quite there, I would say the first conclusion and the first message is partner. You got to have the partners. So are there any questions for us? If so, please, yeah. We will be applying to do that, and that is our plan, to spread the message, you know, as far and loud as we can. Great question. Any other questions? Well, thanks so much, guys.
Thank you.